Welcome to the AUA Inside Tract Podcast. Today's Inside Tract Podcast is part of the Meet the Subspecialties series and is brought to you by the Residents and Fellows Committee. Dr. Meredith Wasserman, first-year FPMRS Fellow at NYU in New York City, sits down with Dr. Jason Kim, Associate Professor of Urology at Stony Brook University, to explore the subspecialty of female pelvic medicine and reconstructive surgery.
Great. So I'm Dr. Meredith Wasserman. I'm a first-year fellow in FPMRS at NYU. I'm here tonight with Dr. Jason Kim of Stony Brook Urology. Dr. Kim, would you like to introduce yourself?
Hi. I'm a urologist at Stony Brook on Long Island. I did my residency at Stony Brook for 6 years, and then I moved to Seattle and did a 2-year FPMRS fellowship with Kathleen Kabashi, and I finished that in 2011. Since then, I've been on faculty at Stony Brook. Currently, I'm associate professor of urology there, and I'm also the director of a multidisciplinary women's pelvic health and continence center.
Very interesting. So I'm very excited to be here with you tonight. We're going to be discussing FPMRS fellowship as part of the Meet the Subspecialties series on the AUA Inside Tract. So I wanted to start first by just discussing the specialty. What led you to pursue FPMRS as a subspecialty?
Well, honestly, luck. When I was in residency at Stony Brook, we did not have an FPMRS trained faculty member, so I did not have much exposure to it. We had one old-time urologist who dabbled in it, so I saw some of the cases. But really what opened my eyes was that I was invited to a preceptorship. Right now, that preceptorship is sponsored by SUFU, but back when I was a resident, it was actually held at Cleveland Clinic. I believe it was sponsored by Cleveland Clinic. And we spent a couple days with experts in the field learning about the conditions and the treatments. And it really opened my eyes. I hadn't been exposed to a lot of that, and it got me very excited about the field. And after that, after coming back from that course, I decided to apply for female urology, even though I didn't have much guidance from my home program because there was no one that could mentor me.
I think that's probably an experience that a lot of people share. There aren't a lot of fellowship trained FPMRS out there. So if this is some of our listeners' first encounter into FPMRS, what does a typical week look like for you with respect to your operative cases or pathologies that you're treating in clinic?
Well, my typical week, I spend about 2 days in the OR, 2 days in the clinic, and then 1 day I have for academic, administrative, or kind of overflow OR time. In the department, I'm actually the residency program director and also the FPMRS fellowship director. So there is a fair amount of admin required. And my ORs, I alternate weeks between the main OR and the ambulatory surgery center. In terms of the clinic, I'm in the clinic 2 days a week, and we have a regular patient load. I'm lucky to work with an MP and PA, so we all see patients together. We run a full urodynamic schedule. We have a nurse who does that. And also throughout the day, we'll do many procedures such as bladder Botox injections, periurethral injections, PTNS, and percutaneous nerve evaluation. So it keeps us quite busy. In terms of the kind of conditions we see everything. I mean, of course, most of our patients have urinary incontinence, overactive bladder, pelvic organ prolapse, urinary tract infections, pelvic pain. I see a fair amount of neurogenic bladder patients, particularly with multiple sclerosis. We have a very close relationship with our multiple sclerosis center, and their neurologists realize that we have a lot of effective treatments for avoiding dysfunction related to multiple sclerosis. So we're referred a lot of those patients. I still see some general urology. I still enjoy doing some of that too, some of the stones and some of the other things. We get a lot of hematuria evaluations. I'd probably say my breakdown is probably about 80% FPMRS and about 20% general urology. I mostly see females. I'd say 90% of my patients are women. I do have select male clinics. We're at a women's center, so because of that, I am limited to mostly seeing female patients.
Do you think that that's generally kind of the same across the board for most FPMRS, or is there some variation in the gender breakdown of patients they're seeing?
Yeah, I think most FPMRS providers see mostly females. However, I think there can be big variations in whether they see in the percentage of male patients they see. Uh, Before we started our center, which is actually a standalone center distinct from our main urology department, my clinic hours were mixed with males and females. I used to see more male patients. And I think one of the beauties of FPMRS is you kind of tailor your practice to what you want to do. Before we had the center, I used to do a fair amount of prosthetic work in males, just because in fellowship I had a exposure to that aspect of urology, and I enjoyed it. You know, as we moved to the women's center, I kind of tailored more to females, and I think that's one of the beauties of FPMRS. You could kind of pick and choose what you want to do in your career.
It seems it's a very wide breadth of options there. And going off of that, what would you say is the most satisfying part of your job? And conversely, what is the most challenging aspect that's unique to FPMRS?
Yeah, you know, it's interesting because when I first told people I was applying for FPMRS, oftentimes I got the reaction, "Why would you want to do that?" You know, people told me the patients are difficult, they're unappreciative. You know, you're going to subject yourself to a life of complaining patients. I find the exact opposite, and that's what I find most rewarding. I get a lot of patients who come in who are frustrated, who have lost hope. You know, patients with an overactive bladder who've been cycled, let's say, on medications for 20 years. And they come in saying, "I've seen 3 urologists, I've been on 5 medications, and they tell me nothing else can be done." However, when we start telling them about other medications or minor procedures, you know, such as Botox or sacral neuromodulation, they realize things can be done. And once we start initiating these things and seeing improvement, you know, they'll tell you what we've done is life-changing. I think that's one of the most rewarding parts of my job.
That's incredible. That's incredible. It's a great turnaround with patients and just seems a lot of instant gratification too with patients. What do you see changing in the field of FPMRS going forward? Any new techniques or changes in the job market?
Right. So actually, I love FPMRS because we are constantly evolving. You know, I'll give you this example. When I first started, when I was in fellowship, we used to admit our sling patients overnight. You know, and things have changed dramatically. You know, the cases that I used to do in the beginning of my career in the main OR, they've kind of been pushed to the ambulatory surgery center, and the stuff that I used to do at the ambulatory surgery center has been pushed to the office. You know, so this constant, you know, we keep kind of figuring out how to get things done more efficiently, which I like. You know, I joke with my residents, I've achieved my goal that I'm now completely an ambulatory surgeon. You know, after COVID started, we started sending a robotic sacral colpopexies home on the same day. I know people have done it before. We hadn't done too much of that before, but with COVID coming, you know, we told the patients that's how it is, and it seems to be working out. So there's that constant transition. But also, I think FPMRS is on the forefront of technology. I'll give you some examples. You know, I love neuromodulation for overactive bladder. And when I was a resident, basically all we had was Interstim, the old Interstim. And, you know, it was not MRI compatible. It had a lot of limitations. The battery life wasn't that great. And the amount of changes we've seen in the past few years is just astounding. You know, they have rechargeable devices, 15-year batteries, much smaller devices, MRI compatible. And now we're branching off into tibial nerve stimulation. You know, it used to just be PTNS where through acupuncture. Recently, eCoin was just approved, which is an implantable tibial nerve stimulator. And parts of some trials for other new devices. So I think the field is constantly evolving, and I love being part of that. You know, as part of this evolution, you know, we're asked often to be part of the clinical trials, and I also enjoy that aspect of my practice.
You're definitely doing a great job of selling it, certainly for people who are interested in technology. So if we've caught a couple listeners here and they're interested in applying to FPMRS, can you talk a little bit about what the process is in applying to FPMRS?
Yeah, sure. So typically in your second to last year, you know, it differs if you're in a 5 or 6 year program. Typically in your second to last year, I'd say towards the winter time, you submit an application for FPMRS. I think programs start getting the applications around the new year. And things have changed a little bit with COVID. In the past, the vast majority of interviews would often happen at SUFU and the AUA in person. But I think now we're mandated to do virtual interviews for the time being. So I don't know how things will change in the future. But regardless, most programs still have kind of meet and greets at SUFU where you can sit down with each program and the physicians there and kind of get a feel and flavor, and you get a chance to meet the fellows. Going to SUFU is an amazing experience because you can meet everyone and they're very friendly. It's a very, everyone's open and they're willing to discuss their programs. And then after you interview, the rank lists are due in July. I believe this year was July 22nd, and we're actually coming up to our match date, which I think is August 3rd next week. So it's an exciting time.
And for people applying, it's usually through ERAS and the NRMP. It's a more formalized application process. Is it when we're going to meet people at SUFU, is it something that people are reaching out to programs on their own, or is it something they're doing through the system?
Well, no, typically the programs are reaching out to the candidates and saying, if you're at SUFU, we'd like to meet you and sit down and talk to you. So I think for the vast majority of programs, it's the programs that make the effort to reach out to the candidates. They'll send emails and things.
Okay. Now, FPMRS is a somewhat unique fellowship in that you can get there through GYN residency or urology residency. So can you talk a little bit about the various types of programs, specifically those that are kind of GYN based versus urology based or integrated, and also the accreditation status of programs?
Sure. I mean, so I was actually, I started fellowship in 2009, and that was the first year that it was from the urology side. It was a 2-year fellowship, and you had to be an accredited fellowship. Historically what happened is in the urology field, most fellowships tended to be 1 year, and there wasn't a separate accreditation process. But circa 2009, the American Board of Urology and the American Board of Obstetrics and Gynecology, that kind of came together and decided it should be a separately boarded subspecialty. And when that happened, it became a 2-year fellowship for urologists and a 3-year fellowship for gyne residents. So, but over the years, there's been some integration. And basically, if you're a urologist, you can apply to the different, if you're a urologist, you can apply to urology programs or integrated programs. And in certain cases, you can apply to gyne-based programs and vice versa. In the end, both the urology-based programs and the gynecology-based programs take the same board certification test, which is a written exam after you complete your fellowship.
A little bit confusing, but I think you did a great job of explaining and laying it out for everybody. And so what qualities should someone be thinking about or looking at when considering programs or deciding where to apply and interview?
Right. I think there's 16 programs right now, and I think every program will get you the basics for FPMRS, the bread and butter, the meat of what you need to study. But each program has a little bit of a different flair. For example, I told you the program I did a fair amount of male recon work, prosthetic work. I know some places are very heavy on neurogenic bladder and reconstructions. So each program has a little bit of a different flair. Some places might do more vaginal surgery as opposed to minimally invasive or open surgery. So I think it's up to the applicant to kind of get to know the programs. You can reach out. In my experience, all the program directors are extremely accommodating and willing to talk to residents or even medical students to kind of get a flavor of the program. And the applicants, I think they have to decide if they want, even within FPMRS, are there different areas that they like to pursue?
Yeah, I'll echo that. I think a lot of the fellowship directors were very open about explaining their programs. There's also a series on the AUA University podcast that goes through a bunch of the FPMRS fellowships and asks about the breakdown. And I found that really helpful when I was applying. So there's definitely a lot of good information out there. If there are any med students tuning in, how would you guide a student who is deciding potentially between GYN and urology with regards to someone who might be interested ultimately in hitting urogyne or in voiding dysfunction of some sort, but they're debating between two residencies?
Yeah, that's a great question. And I've actually, a lot of medical students have come up to me and kind of asked me that. I think they should spend as much time as they can as a medical student with each field. In fact, I encourage medical students, even in their first year, to seek out shadowing opportunities in urology and gynecology to kind of get a flavor of what the residency is like. In my experience, I think gynecology tends to have a little bit more of a primary care focus. A lot of women use gynecologists as their primary care physicians in a way, whereas urology tends to be a more surgical field. And I think the students should kind of rotate with both services and kind of figure out which aspect they may like better or where they may feel like they fit in better, and then the decision can be made from there.
Okay, that's fantastic advice. Any other thoughts or advice about the field?
Yeah, I think it's a fabulous field. I think we desperately need more people going into FPMRS. One thing I will say for the residents listening in, the job market is fantastic. I feel like you can get a job almost anywhere in any major city, major academic programs. A few months ago, I was talking to a lot of the program directors, and they were lamenting how hard it was to find people to fill vacancies. I'll give you an example. We're at Stony Brook. We're about 60 miles out of Manhattan. Every time we post for example, urologic oncology opportunity, we might get 20 applications overnight for that position because it's for people who want to be in the New York area. It's close enough to the city and they want to be there. Whereas for FPMRS, we've posted twice, and each time it's taken us about 3 years to find someone. So the job market is fabulous, and there's, I think, an exploding need for the FPMRS physicians. The other thing I'll say to medical students is, don't get discouraged if your program, if you can't find someone in your program, to mentor you for this. I would say, reach out to people in SUFU. If a medical student reached out to me, I'm more than happy to mentor them. And I think multiple, the directors or faculty to other programs would be the same way. For residents, SUFU used to host a resident program for residents who came from programs that did not have FPMRS exposure, where they could apply and spend a week at a different institution, maybe a high-powered FPMRS institution. I think during COVID, that program kind of was temporarily halted, but I know they want to actively bring a program like that back. And, I think that would be beneficial. And for any residents or medical students out there, if they have any questions about that, I encourage you, feel free to email me or contact me. My email is jason.kim@Stony Brook Medicine, and I would be happy to answer any questions and provide guidance on the whole process.
That's very helpful. I think as much as we can kind of get FPMRS out there and kind of be shouting about it and try to get people interested, because not only is it hard to get exposure to urology, it's even harder to get exposure to FPMRS as a medical student. So thank you so much, Dr. Kim, for joining me tonight. And to our listeners, again, please feel free to reach out to myself or Dr. Kim. We're both also on Twitter if you want to follow us on there or reach out through our messages. Dr. Kim is at Jason_Kim_MD, and I am at MC Wasser MD. Hopefully this podcast has been helpful for everybody, and thank you, Dr. Kim.
Oh, thank you for having me. It was a fun experience.
This has been an AUA Inside Tract podcast brought to you by the Residents and Fellows Committee. Check out the AUA University podcast for weekly episodes on the latest clinical updates and advances in urology. For more information about the AUA and membership, visit auanet.org.